Hello, everyone. This is Ragunath here from Perth, Western Australia. Thanks for joining us today for an exciting program on predictors of adverse events after endoscopic ultrasound guided through the needle biopsy of pancreatic cysts. Whichever part of the world you're joining us from, good morning, good afternoon, good evening. We have an exciting line of speakers today. And first of all, I would like to welcome and thank Dr. Reddy, who doesn't need introduction to the endoscopy world. Nagi was the first WEO president and quite instrumental in getting the WEO to where we are today as a voice of world endoscopy. My co-chair today is Dr. James Law, who is representing the Asian Endoscopy Research Forum. And again, James doesn't need introduction to the endoscopy world, and he has been a pioneer in several intervention endoscopy procedures. So both of us are going to be co-chairing the session, which Dr. Reddy will be chairing. Following that, we'll have a presentation from Dr. Cesar Capel from Brazil, and the discussants will be Dr. Fauze Maluf-Filho from Brazil and Dr. Raymond Tang from Hong Kong. So let me hand you over to Dr. Reddy. Nagi, to you, please. Thanks.
Thank you, Chris. I think we have a very important webinar this afternoon in India at least. Rest of the places, different times. And this is a very important question that's going to be discussed in the Journal Club on the predictors of adverse events after endoscopic ultrasound guided needle biopsy of pancreatic cyst. I think increasingly, pancreatic cysts are now being diagnosed more accurately with biopsy through the needle. And this through the needle biopsy has revolutionized our diagnosis because we're getting an accurate histopathology of the wall of the pancreatic cyst. And to discuss this very important topic, initiated in the Journal Club, we have Cesar Capel from Brazil, who will present this. And we have, again, two very experienced investigators who are going to discuss this paper. Fauze and Raymond, of course, are from Brazil and Hong Kong. And we'll also have a chat box in which you can send your questions so that we can continue with the discussions. Okay, Cesar, can we have the presentation, please?
Sure, Professor. I am sharing the screen with you. You can see the presentation?
We can see the presentation. Please go ahead.
Okay. So my name is Cesar Capel. I'm from Brazil. I am working at the Cancer Institute of São Paulo with Professor Fauze Maluf-Filho, who is the director of the unit, endoscopy unit. First of all, I want to thank Professor Fauze for this opportunity. It's a privilege for me to participate in such an important event with these big names. And today we'll discuss the paper from this recently published on endoscopy, named Predictors of Adverse Events After Endoscopic Ultrasound Guided Through the Needle Biopsy of Pancreatic Cysts, a Recursive Partitioning Analysis. So this is the members of this webinar already presented. The learning objective is to discuss the role of EUS-guided microforceps biopsy in the diagnostic algorithm of pancreatic cysts and understand the diagnostic yield, risks, and predictive factors of adverse events of this novel modality of tissue sampling in pancreatic cysts. This is a picture of the Morai microforceps with the serrated jaws to acquire tissue samples. It has a spring sheet allowing using turtles positions, and it has compatibility with the most 19 gauge FNA needles. Taking the importance of the accurate assessment to adequate patient management in PCL, in pancreatic cystic lesions. This through the needle biopsy is associated with higher diagnostic sensitivity and accuracy when compared to US FNA. However, the adverse event rates reaches up to 10%. So the risk stratification of these adverse events could be helpful. The aim of this study, this paper, is to identify the hierarchical interaction among independent predictors for through the needle biopsy related adverse events to generate a prognostic model using this analysis, this model, this recursive partitioning analysis. The final goal of this approach is to determine an easily interpretable method for classifying patients that could help clinicians in their decision making. The methods of this study: data was obtained from multi-center retrospective analysis of more than 500 patients with pancreatic cystic lesions who underwent through the needle biopsy between 2016 and 2021. The authors supposed that classical logistic regression may not be able to identify potential interaction between different risk factors. So they made this recursive partitioning analysis method. Generally, the indications for through the needle biopsy were one or more of the following, like presence of pancreatic cysts greater than 3 centimeters, mean pancreatic duct diameter bigger than 5 millimeters, size increase or changes in morphology during the follow-up of the patients, thickened walls or mural nodules, and increased serum CA19.9 level. The primary outcome is to determine the hierarchy of clinical and procedural prognostic factors able to predict the occurrence of adverse events to define risk groups that could help clinicians in their decision making. The adverse events were classified according to the ASGE lexicon, and they are listed below, like perforation, bleeding, hemorrhage, pancreatitis, infection, and abdominal pain. The secondary endpoints was the diagnostic yield and accuracy. The yield was defined as the percentage of the lesions sample for which a tissue diagnosis was obtained, and the accuracy was defined as the percentage of lesions that correspond to the final diagnosis in an intention to treat analysis. And the gold standard for diagnosis was the surgical histology whenever this was available. So starting the results, this is the baseline characteristic of the patients. The mean age was 62 years. Most patients were asymptomatic. The commonest indication for the procedure was lesions bigger than 3 centimeters, followed by increasing the dimensions during the follow-up, and suspected mural nodules and thickened walls, sorry. Continuing in the results of the procedures, the mean number of microforceps passes was 2.5. The cyst was aspirated entirely in 72% of the patients. Antibiotics were used in the majority of patients, and the mean follow-up was 14 months. The final diagnosis was most IPMN, followed by serous and mucinous cystadenoma. A detailed list of adverse events is presented. The rate of adverse events ranged between 9.5 and 13.2 among the centers, without significant difference. Overall, the adverse event rate was 11.5. The most frequent adverse events were acute pancreatitis with 5.7%, fever infection with 2%, and intracystic bleeding with 2%. The analysis showed that patient age over 64 years, number of microforceps passes, complete aspiration of the cyst, diagnoses of IPMN were found to be significant predictors of adverse events in both univariate and multivariate logistic regression analysis. The importance of these variables in predicting adverse event occurrence was confirmed by a random forest model with those 4 variables taking the lead. From that was generated a recursive partitioning classification tree for the occurrence of adverse events that split the whole patient series into 3 groups: low, medium, and high risk. The stratification was based on diagnosis of IPMN, number of microforceps passes, complete aspiration of the cyst, and age, namely those variables presenting the higher importance in the random forest model. The analysis demonstrates that patients with IPMN reached 28% of adverse event rate when more than 1 pass of microforceps is performed, and the rate fell to 6% when only a single microforceps pass is performed. Other patients falling into this medium risk group include those with a diagnosis other than IPMN, whose cysts are not completely aspirated, or are fully aspirated but sampled with more than 2 passes, and those patients who underwent complete aspiration of the cyst with no more than 2 microforceps passes, but are aged older than 64 years. At the other extreme, the low-risk group included only patients younger than 64 years with a diagnosis other than IPMN, who underwent complete aspiration of the cyst and tissue sampling with no more than 2 microforceps passes. This table showed that not only the adverse event rate, but also the severity of the events differed significantly among these 3 groups. So, the 3 fatal events and the majority of moderate severe adverse events occurred among the high-risk group. The secondary endpoints, the results were diagnostic yield 80.8% and diagnostic accuracy 83.3%. The discussion the authors done. This study represents the largest series ever published on the use of through-the-needle biopsy. It was the first attempt to build a prognostic model for adverse events occurrence by means of recursive partitioning analysis. And this analysis, this model performed in the current study may capture all possible interactions of the prognostic factors, including multiple splits in the same variable. Once that single pass may be not sufficient to achieve adequate samples for histological diagnosis, and if, like the study demonstrate, IPMN multiple biopsies leads to an adverse event of 28%, these results go against sampling through the needle biopsy in IPMN patients. The authors still keep the discussion. To avoid through the needle biopsy in IPMN, they recommend exploring imaging resources with relatively high sensitivity, like magnetic resonance or EUS. Even so, sometimes IPMNs are unifocal, and the communication between the cyst and the pancreatic duct is difficult to assess. Another debatable advantage of the through-the-needle biopsy is to define the grade of dysplasia, but may be underestimated once the specimen may not be representative of the whole cyst. Moreover, IPMN risk stratification can be accurately predicted in the basis of clinical and radiological features. So, once again, given this higher risk of adverse events in patients with presumed IPMN, TT and B should be avoided. The authors conclude that through-the-needle biopsy should be avoided in patients with a presumed IPMN, whereas it seems safe in patients younger than 64 years with pancreatic cystic lesions not in communication with the main pancreatic duct that are sampled with 2 microforceps passes and completely aspirated. Thank you.
Thank you very much, Cesar, for that excellent presentation of a very important paper, because I think this paper actually resolves many of the problems we have in the practice of through-the-needle biopsy of pancreatic cysts, which is becoming an important modality of how we diagnose these patients. So we got some very important messages not to do biopsy, at least multiple biopsies in IPMN, probably because it's communicating the pancreatic duct, and to limit the number of passes to 1, not more than 2 especially. So I think we'll go to the discussion now. We have Fauze and Raymond. So we'll start with Fauze. What are your comments on this paper, Fauze?
Well, first of all, good morning from Brazil. Thank you, Nagi, from the presentation. Thank you, Krish and James, for the invitation. It's a huge pleasure to be here with Raymond and Cesar. And thank you, Alana, for the organization of this webinar. So, Cesar, congratulations on this nice presentation. I think that this paper by Faccio Russo and collaborators, this paper has relevant message to the gastroenterologists and US practitioners. We know that most pancreatic cysts are incidental findings, meaning that the vast majority of the patients are asymptomatic. Actually, in this paper, 70% of the patients were asymptomatic. So when you take this into consideration, we should be aware of the invasiveness of the investigation that we're gonna submit our patients to. So when we look at this paper, we notice that 17 centers were involved, and the adverse event rate varied between 9.5 to 13%. So it means that the adverse event rate when we do through the needle biopsy of pancreatic cyst is around 10%. And I think the 10% adverse event rate is way high for this kind of population. We're talking about asymptomatic patients. And for most of them, the clinical impact of the pancreatic cyst will be very low. So when we look at the paper data, from the 500 patients, only 7% of them had clinically meaningful cysts. I mean, neuroendocrine tumor, pancreatic cancer, or Franz tumor. So only 7%. So 93% of the patients, they had benign cysts with very low clinical impact. So I think that we should be aware too that maybe it's not a good management to offer a 10% event rate to a patient with very benign condition. So, and when we talk about 10% adverse event rate, among these patients, we are talking about 2% of severe adverse event rate, 3% of moderate adverse rate, and 0.6% of mortality. So we're talking about diagnostic workup with a 1% risk of death. So I think that this is way too much for this group of patients. No doubt that the needle biopsy has a higher diagnostic yield and higher diagnostic accuracy and sensitivity compared to USFNA. So in this sense, it was a huge development for US practitioners. However, we should take into consideration this high risk of adverse event rate, especially severe and moderate. So in this sense, I think that the paper has a relevant contribution trying to indicate the patients who are at higher risk for this procedure, and the patients who are older, who the probable diagnosis is IPMN, and when you perform 2 or more passes, then this group of patients are at higher risk of complication. So you could say, if you think this up IPMN and you see a mural nodule, you could do only 1 pass. But there is this paper by Crino and collaborators that show that the good number of passes of through the needle biopsy passes, the good number is at least 2 passes. And Cesar showed that when you do 2 passes in a patient with IPMN, you put this patient at the high risk group, meaning 30% of adverse event rate. So you see, so that's why the paper concludes that maybe you should not perform through the needle biopsy when you think that this patient has IPMN. So you do EUS, you see a communication, a clear communication between the cyst and the duct. So maybe you should not perform through the needle biopsy. Another point that I think it's worth exploring in this paper is that only 25% of the patients received pancreatitis prophylaxis. Only 25% of the patients received indomethacin, rectal indomethacin. So maybe these numbers, the number of adverse event rate, could be lowered if we use systematically rectal indomethacin, as we do nowadays for ERCP, right? I think that in most practice, doctors use rectal indomethacin to prevent acute pancreatitis when doing ERCP. So maybe we could do it for this situation, or at least conduct a randomized control trial with rectal indomethacin versus nothing, versus the best treatment in a group of patients of high risk for pancreatitis or high risk for complication when performing through the needle biopsy. So if you take this high risk group here and you want to perform a randomized control trial comparing indomethacin versus rectal indomethacin versus placebo. So I calculated the sample size. The sample size would be 50 patients in each arm to perform this randomized control trial. I think that 2 or 3 centers could gather and conduct this trial. Wouldn't take long. So these are my considerations. Thank you.
Thank you for that, I think, very balanced review of the paper, and also giving us a few suggestions on how we can proceed further in improving the quality of these studies. And I agree with you that maybe for IPMN patients, other modalities of diagnosis, which are very certain, could also be complementary, and we have to weigh carefully before we do multiple passes in these patients. Raymond, can we have your comments? Yeah.
Yes. Hello. So thank you, Nagi. So good to see everyone here. So, first of all, I would thank WEO and AERF for organizing this. And so I actually echo a lot of points raised by Fauze. And so what I want to add to the discussion is actually we want to look back at the patient characteristics here. So they include the number of patients with a cyst size greater than 30 millimeter, a 3 centimeter cyst, and also those greater than 1.5 centimeter cyst. So now the proportion will be 42% for those patients with a cyst size greater than 3 cm, and 12% with a cyst size greater than 1.5 cm. And that means the rest of these patients have a relatively smaller cyst. And I argue now some of these could be relatively asymptomatic, and then a lot of these maybe not even require routine EUS surveillance, or even, for example, a puncture with the through the needle forceps. So, so this was kind of one of the situations that there are also conflicting recommendations, for example, based on international consensus guidelines, such as the Fukuoka guidelines. And so because some of these could be surveyed with non-invasive imaging. So, and I guess, for example, if we have MRCP, then the relationship between the cyst and the main pancreatic duct could be also delineated non-invasively. So these my points regarding, for example, who should get this investigation. And another thing about the number of passes is, I think as endoscopists, obviously we would like to, get the job done with as little biopsy passes as possible. Just like, when we sample indeterminate bile duct stricture with, like the cholangioscopy-guided biopsy. So, but I think here, this forceps is arguably very small also. And I think in practice, it's hard to really get a diagnostic tissue size with just one bite. I think a lot of us may not be confident enough to just do one bite. For example, most of us won't be doing rolls. So then we need to rely on sending tissue to the pathologist. So that would be another take on this. I think ideally I would love to just get it done with one pass, but maybe it's hard to do. And also, I think we all like to embrace, new technology with potentially higher diagnostic yield. I think certainly microforceps is one of these new technologies, but I feel that perhaps it's not for everybody. Just like what this, analysis have shown us, maybe there will be patients who are already in a high-risk group, for example, due to the morphology of the cyst. For example, a very septated lesion, that will make it very hard to empty the whole cyst, even with a single puncture. But if we keep, breaking up the septations, then I think there will be risk of bleeding or, things like that. So these will be my take on this.
Thank you, Raymond, again, for giving another angle and some very important points that you brought out. Before we go to our coaches, two things. One is to Cesar, was there any data on antiplatelet use in these patients? Because we know that if the patients are on antiplatelets, the bleed chance would be higher, and we don't have any recommendations what to do in these cases. Is there any data? I didn't see it in the paper.
No, I didn't see any data about antiplatelets.
So I think that would be important, because many of these patients are elderly, they are on antiplatelets, and maybe the recommendation should be, if you're taking at least multiple to stop the clopidogrel part, you can have aspirin in these patients. I think we still don't have data. And maybe Fauze could give us some idea on, again, another study that you're suggesting for pancreatitis, whether we should also include antiplatelet agents as one of the things. And maybe aspirin alone may be okay in these patients, I think.
I think you raise a very important point, because when we think how this through the needle biopsy could cause pancreatitis, I think that the mechanism probably is bleeding and creating clots, and these clots migrate from the side duct to the main duct and obstruct the duct and cause pancreatitis. So I think that the coagulation issue is crucial for this situation. So I think that probably in this situation, we should be very strict regarding the use of antiplatelets and anticoagulants in this group of patients.
Thank you, Fauze. And then we have one question from Pakistan in the chat box. Dr. Sahid wants to know what to do for IPMN patients. We feel that through the needle biopsy is risky. Should we avoid it completely in IPMN patients? He wanted to know that. This could be open for everybody.
Okay. Raymond, want to take this?
Yeah, Raymond, you want to?
Sure. Yeah. So I think, if before we do the EUS, we already have some suggestion that this may be an IPMN, for example, an MRCP showing communication with the main duct. I would say I would tend to be less invasive. For example, well, maybe I would still do the EUS just because, for example, it's a big lesion, just to make sure I don't see any, like small mural nodules, but other than that, like I may not need to puncture, but I think if, for example, the procedure investigation is less conclusive, then yes, I may consider, but certainly not for everybody.
Thank you, Raymond. I hope, Syed, you got your answer from this. I've seen James writing vigorously during the whole procedure. Maybe some additional golden comments from you?
Oh, I wanted to ask Cesar a few questions. I'm not familiar with recursive partitioning analysis. Could you let us know what it means? I actually briefly looked it up, and it is a form of multiple regression analysis, and there's also it also involves a decision analysis. Am I correct?
So, Cesar, RPA. What is RPA, James?
Yes, I searched for, and the authors pronounce the explanation for this analysis, and that's what I find. Like you, Professor, it's a way to create trees in using multiple variables and testing all the sets. So this variable. After this variable, yes or no, and testing, and above they continue to testing, and so is this. This is the first time I read something about that, and it's very interesting, but I don't know technically how to do it specifically.
And your manuscript is based on a retrospective collection of data over 500 patients. Do you think this needs to be prospectively validated? I'm just referring to the limitations of retrospectively collecting data.
Yes, sure. The prospective study will bring us some results, more confident, more strong results. But they use this RPA method, trying to gain force to this analysis. I think so.
Okay. Yeah. Right.
I think that James brought an important issue here. So now that we know that we are facing 10% adverse event rate, could we do a prospective study just to prove the results of this retrospective one? I think this is difficult to say. Very difficult, right? That's why I think that the next step should be a randomized control trial comparing something to prevent acute pancreatitis versus the best treatment. So randomized control clinical trial, RCT, comparing rectal indomethacin versus a control group to prevent acute pancreatitis. But I'm not sure if we could conduct a prospective study like this in face of this 10% adverse event rate.
I think, Fauze, you make a very good point. I think we require that because 10%, even by ERCP standards, is quite high. And therefore, I think it's very important. And if you take this as a multi-center study with this high incidence of IPMN that we see now, I think it should not be so difficult to get 50 cases in both arms, especially if you're going to look at, because there is clear evidence that multiple passes are better than a single pass in terms of histology in trying to grade these tumors. So I think it's very important to do this study. Otherwise, you can just aspirate the fluid and do what we're doing now, which is as well the same procedure, which doesn't have an increased pancreatitis risk. So if you're going to go one step ahead, I think it's very important to do this study that you propose in a prospective randomized control manner to determine whether the risk is as we've seen in this study and whether we can actually prevent it by using rectal indomethacin. Chris, you have any comments?
Yes, and thank you very much for that. There are a few observations I made in this. First of all, as Fauze said, IPMNs are, especially when they are diagnosed asymptomatic, generally of the low risk. If they present with an episode of acute pancreatitis or a jaundice, then the alarm bells ring that there is something going wrong in that. And quite often with the MRI and MRCP these days, you're able to get as much information as you want in diagnosing IPMNs and also quite a few of the cystic lesions. And there's very small, narrow areas where you would really want tissue diagnosis of the cyst wall. Given the fact that it is more of a benign, most of them are quite a benign nature. One important thing which I noticed that there have been 2 fatalities from acute pancreatitis, which is quite a big thing. In 500 patients, 2 patients have died purely because we went and did something to these patients who were totally asymptomatic. So that's something we need to really consider. The things where I have done it in a few cases where sometimes we can have cystic lesions where there is a suspicion of whether this is a neuroendocrine, cystic neuroendocrine lesion, and biopsying the wall makes a difference in these patients. But you can get most of the information on cross-sectional imaging and then choose the cases where you really want. And also take all measures to prevent post-biopsy pancreatitis, because it looks like if you get it, you get a fulminant pancreatitis, and that's something which we need to take in point. But one other comment here is a few years ago, the PCLE became quite popular. Which is quite a non-invasive way of doing it. And Fauze, you might remember this. There's quite a few studies where through the needle PCLE was done, and we had quite a high sensitivity and the typical pattern of what you would see in the different benign versus malignant cysts. And how do you compare that with doing a biopsy, because it did not have this high rate of adverse events? Thanks.
Thank you, Krish. I think you raised a very, very relevant point here, because now in face of the results of TT-BN, of the through the needle biopsy, I think it makes more sense now to perform confocal endomicroscopy. Less invasive, less complications, and you have very good information. There, as you mentioned before, there are some signs, some images that are very compatible with IPMN, and even you can tell that there is some risk of dysplasia based on the image. So I think that maybe this paper maybe increased the indication for confocal endomicroscopy. The problem here is again the costs of confocal endomicroscopy. The probes are expensive, they're fragile, and this is an issue. Another issue that you need to inject contrast. You have to inject fluorescein, and there is the minority of the patients may present some adverse allergic events, but still, I think it's minor problem, and you have also the problem with interpretation. But again, I think there are some studies showing that the learning curve is not so steep, is not so high. You can learn the pictures and learn the image, and also I think that the equipment has an atlas inside the equipment, right? You can compare the image that you get with this atlas that is incorporated within the equipment. So I think it's a way to explore, further exploration.
So Chris, is PCLE still available? I thought it's still not available. In fact, long time since I've seen any demonstrations being done with this.
Yeah, as I said, a few years ago, it was popular with the Mauna Kea probe, which was done. I've not personally done anything here in Australia as such. We were doing a few in Nottingham when I was there, but I just brought up the discussion to see how it compares with this technology. But what I'm struggling to find is the indications to do a cyst wall biopsy is very narrow. And with the amount of good quality, high resolution cross-sectional imaging. And obviously, if there is alarm symptoms, if the patient presents with the pancreatitis, then you know that something is going wrong and you don't want to miss out a small pancreatic cancer. And that's where it all narrows down. Yeah.
Yeah, I agree with you. I think what we should also do is to actually compare what we normally do, all these advanced imaging techniques, and just with aspiration of the cyst, fluid, we get so much information now.
Yeah.
Simple glucose estimation is now shown to be very, very accurate in differentiating those cysts which require an intervention surgically or those who don't. What you're looking at here is not an accurate diagnosis. We're trying to look at high-risk cysts which have to be operated on. So I think a simple analysis of fluid very often gives us this information. So also when you're talking about this through the needle biopsy, we should compare with the standard techniques to see whether there's some advantages, especially in view of this paper, which has shown such high significant complication rate.
Nagi, can you advise us? Obviously, you have a big pancreatic research team with the laboratory as well. Obviously, the molecular markers in a cyst fluid, that's a big area. If I'm being investing something, that's where I'll be investing, which will be a non-invasive. Just use a normal 22-gauge needle, aspirate some fluid out, and look for some mutation analysis, KRAS, and plus other things, and then come up with a technology where you can predict what the cyst is, and even the risk stratify the cysts of where you want to intervene, where you want to follow up. So can you just highlight us some of the work you've been doing in AIG on mutation analysis and molecular analysis?
So Chris, right now, our team is actually working on this. They're looking at various mutations that are present. KRAS has been the standard mutation that has been used everywhere. GNAS is another one that's being used, and there's several other mutations, P53 and so on. What is more interesting is that we're actually now linking this with artificial intelligence. You can actually make algorithms based on artificial intelligence, mutations, and the biochemistry of the cystic fluid to come to very accurate diagnosis of over 90+% in these patients. I think that is going to be the future, like you said. Hopefully next 1 or 2 years, we'll get much more information on this. The problem, of course, is what is the endpoint that you have to have a surgical specimen to compare the accurate histology, including the stages of dysplasia to give a very accurate diagnosis. I think we've got to a good accuracy now, and to make it extremely high accurate, we'll have to combine this artificial intelligence mutation with the studies that we're going to get now on histology.
There's one more comment, Maggie and Raymond and Fauze, you might know. A few years ago, Cook came up with a brushing brush through the needle, and we did some work on that as well. And it became less popular because it ended up with a few hemorrhages inside the cyst, and then it completely killed the technology, and Cook stopped producing it. It's again, alarm bells. If you start messing around with the cyst wall, and then even brushing causes bleeding. And then now if you do biopsy, then I'm not surprised that the A&E rate was nearly 10 to 15% in the study. So my message from here is both brushings and biopsy, you are getting a high A&E rate. And as Nagi said, we should be going into more clever things, looking into mutation analysis and more of a precision medicine here, and using AI, which I think is the future.
So the brushes, I think, were fairly crude, and the yield also wasn't as much as the amount of risk you take doing these brushes. So I think eventually they went out. But I think also one of the disincentive for people to develop technology in this area is that our imaging, both with MR and CT, is so good now with these cysts that to a large extent your diagnosis is made, the high risk ones sorted out. And what you have to do is to follow these patients carefully is one of the imaging techniques. So that has been the final outcome for many of these studies now. James, you have any ideas about what we should think going forward in the case?
No, not really. But I think it leaves us a question on the indications for through the needle biopsy. It appears to me from the series that certainly large cysts with IPNN and this patient should not undergo the procedure. And then some of the cysts underwent the procedure unnecessarily. So I think the difficulty here, having read this paper, is to identify the ones that are likely to benefit from through the needle biopsy. So I think I agree with Chris that the indications are in fact very narrow. And most of these patients could just be undergone a program of surveillance.
Yeah, so any last minute comments by Fauze and Raymond?
Just thank the opportunity of being here.
Oh, thanks. Yeah, so I think, again, we'd like to thank the WEO, the World Endoscopy Organization, along with the Asian Endoscopy Research Forum for this opportunity. In fact, this has been a fantastic discussion on this very important paper. We have been thinking that this is a benign procedure. Very often in the workshops, people demonstrate murine needle and everybody is happy about it. I have in fact seen occasions where there's been a torrent hemorrhage just in front of our eyes. And like Fauze said, one of the smaller side branches are involved and pancreatitis develops, the whole cycle of complication and also mortality could come in. So this has been what we found. But now we have a systematic paper which has reviewed this. Although retrospective, I think it's still very important to show us that this procedure is not as benign as we thought. It has to have a definite indication that when you're doing it to the clinical practitioners, the direction is use only single pass, do it for lesions which are not IPMN, you have doubts about other situations, then you can do it. And of course, also it raises some very important questions of, like Chris pointed out, alternative methods of diagnosis, which may be less traumatic than what we're doing now in these patients. So I think these are all very important questions that this paper has raised, and hopefully subsequent papers would be addressing some of this. So again, I'd like to thank WEO for giving us this opportunity to discuss this very important paper. Thank you very much. And I'd like to thank Presenter Cesar for taking this trouble. I know it's a very difficult statistical analysis. In fact, I couldn't even pronounce the word. So unlike James, I didn't ask the question. It was very difficult. I think you did a fantastic job in presenting this. And Fauze, as usual, your wisdom, and Raymond, thank you very much for all your comments. Thank you very much.
A pleasure, sir.
Thank you.
Thank you.
Okay. So we sign off.
Thank you.
See you in Chicago. Bye-bye. Bye-bye. Thank you.
Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you.
All right. Thank you very much. Yeah.